My name is Dr. Tim Benke. I am a pediatric neurologist at the University of Colorado School of Medicine and Children's Hospital Colorado. And I've been asked to talk to you today about GRE disorders and approaches to therapies. Thanks for your time and attention in asking me to present to you today. These are my disclosures. The main ones that are relevant is that we are receiving funding through Simons and in the past GRIN2B and CURE for the evaluation of glutamate receptor mutations in epileptic encephalopathies. I'm the site PI. Dr. Trina Ellis is the overall PI for that grant. Also, I've provided advisory and clinical trials to a number of different entities, but all remuneration has been made to my department. So here's what I'm going to talk to you about today. I'm going to talk to you about existing treatments for epilepsies, spells and storms, sleep, GI issues, and therapies in general, and then talk briefly about N=1 trials. Seizures and spells. What are some key questions? So this is important when you talk to your clinical team about seizures and spells. And it's important that you, as best you can, are able to describe the event from start to finish. Some of the things you want to be able to describe further is, on average, how long do they last? And what's been the maximum duration in the past? When did they start? In other words, this has been going on for a long time or just something recent? And are they still occurring? How often do they occur now? Is this daily, weekly, monthly? And what's been the maximum frequency in the past? It's important to know what happens afterwards, such as sleep, or they go about their own business. And if you've been able to identify anything that seems to trigger these, foods, activities, even sleep, and if anything, such as trigger avoidance may help. And it's also very helpful if you're able to capture this on either your cell phone or if it was lucky enough to be captured when they were hooked up to an EEG or other monitoring study. So with spells and seizures, what are the possibilities? This is important because it determines the treatments. So the description plus diagnostics hopefully gives an answer to suggest a therapy. And this is always a clinical decision. Was this a seizure, a movement disorder, a sleep disorder? Was it autonomic instability? Was it change in anatomy? Was it something behavioral, or is it just unknown? As always, the treatment goals are no seizures, no spells, and no side effects, but this may be a balance you establish with your clinicians. So some diagnostic tests to consider with pros and cons for each. So a cell phone video, I think these are very helpful because it catches them in their natural state. The cons are, it's hard to do. You're trying to look after somebody, but also somehow sprout a third arm to do this. And of course, there's limited physiology that's measured as part of these. Video EEG. These are the ideal recording conditions, but you have to be lucky enough to have one of your spells when you're hooked up to the machinery. The same goes for a sleep study with a video, as well as a cardiogram or a Holter monitoring. Again, these are ideal recording conditions, but you have to get lucky enough to capture them. Imaging studies, so these are useful if there's been an overall change in addition to the new spells. The cons, these are not really useful if it's already been done as part of initial diagnosis. And I don't think that repeating imaging studies such as an MRI of the head is really useful unless for events that come and go and there's nothing new in between the events. So when we talk about seizures, it's important that you work with your clinician to ensure that you're on the same page. You want to make sure that you're calling the same thing, and use the same terminology each time. So if spell A, if everybody decides that this is a seizure and it was a certain type of a seizure, such as a tonic seizure, then everybody should try to use the same terminology. And if everyone knows that you're calling a whoopsie a specific seizure type, that's okay. And then this is versus spell B, which is not a seizure. And of course, we know that differentiating some seizure types and spells is difficult because a brief tonic seizure can look like a spasm or a myoclonic jerk. But at the end of the day, we want you to keep a diary to track what is working and what is not, and the side effects for each spell type. So really, basically, we just want to know is, are we doing anything that's helpful? One of the things that we want to know in general is what seizure types are common in the different GRE disorders. And this is an important question that we're hopeful to answer through the registry. While you fill out forms, if you have notes from your clinicians, please feel free to send those along as well because they're very useful too. So what about epilepsy and grin disorders? So just first of all, for definitions, more than one unprovoked seizure technically is a diagnosis of epilepsy. And what we know so far is that in GRIN1 disorders, there's about 65% of individuals will have epilepsy, and 2/3 of these will have medically resistant, or MRE, medically resistant epilepsy. The age of onset of seizures is birth to 10 years of age, and there's a lot of different seizure types, from generalized tonic-clonic or GTCs to focal seizures to spasms to complex spasms. For GRIN2A, the incidence is about 90%, but a lot of individuals do outgrow their epilepsy. The age of onset is birth to 10 years of age. And again, there's a wide spectrum of different seizure types that are seen with these. In GRIN2A disorders, we do see what we call EEG-only seizures, or continuous spike waves with sleep type seizures. In GRIN2B, overall incidence appears to be less, maybe about just 50% of individuals may have epilepsy, and just half of these may have medically resistant epilepsy. Onset, birth to 10 years of age, and again, a variety of seizure types. GRIN2D, it appears that epilepsy is nearly 100%, and it tends to be nearly all medically refractory. And the age of onset is very early on. And sorry, but the bottom part of my slide got cut off here. But these are just the definitions that are here in the table. So epilepsy treatments. When to treat is the first question. And I think that this has a lot to do with how disruptive was it. Sometimes with a discussion with the family, the decision may be, yes, we want to treat even after just saying one, but that's a decision with the family and your clinicians. And that usually revolves around how disruptive the seizure was. But usually the advice is in a generic way that if you're going to have more than 2 per year, we should probably be treating. And standard therapies for each type should be considered. And specific seizure types often have specific therapies. And those types are based on what we see both on the EEG and also the description that you're able to provide us. And what we're trying to do is to categorize seizures into either a generalized pattern, that is, the seizure comes from all over in the brain at once, versus a focal seizure, which may start in one place in particular, versus another type of generalized seizure, which is called epileptic spasms. And each one of these may have specific treatments. But again, the goal is to reiterate, no seizures and no side effects, and each medication is going to have different side effects. One of the things to talk about are what's been called storms. And storms are, in a very broad definition, these are non-epileptic, non-seizure events associated with signs and symptoms of inconsolable irritability, discomfort, and often increased heart rate and sweating. They may last for hours until exhaustion followed by sleep. And it's important to work with your clinicians to try to identify triggers and therefore trigger avoidance. And to really, I think, when you get to this point, part of the definition is that you've determined that they're non-epileptic. And so that's really going to influence how you approach therapies to these. But some of the considerations could be things that target autonomic features such as clonidine, or may even be in the sedating category or mood stabilizing category, such as things like gabapentin or even anti-anxiety medicines. So how often do we see these with GRI disorders? And what works best? These are really important questions that we would like to answer. And so that's one of the issues that we're trying to tease out through the registry. So seizures and spells, just to wrap up. So therapy depends on what caused the spell, the nature and the physiology of the spell, the impacts of the spell, the side effects of medication, and the safety and efficacy of approved medications. And safety is, I think, always a very important concern, if not the top one. And you want to ensure the safety of the individual during a spell. And so I call these the 3 T's and a 4th T of seizure first aid. The first one is time it. So for seizures, if it's longer than 5 minutes, we think that that's when you either need to up the game with either calling emergency services or consider use of a rescue medicine. Then being on your tummy or your side is a good place because it helps to protect the airway. Tongue, don't worry about it. We used to be concerned about people swallowing their tongues during a seizure, but if it's a seizure and you put your finger in there, you'll get bit, or if you put a spoon in there, you'll break a nice tooth. And the fourth T, this is the fourth T that's not essential. It's T-Mobile. If you can pull out your phone and video it with your third arm while you're taking care of your loved one during a seizure, then that's also very useful to us as clinicians. Sleep disorders. So this is an approach to not sleeping at night. So important questions are, is it a problem with going to sleep or staying asleep, initiation or maintenance? And then other questions that are important are there snoring or other disturbances such as movements that are interrupting sleep? And then other important questions are, is the child too sleepy during the day because of not sleeping at night? And then of course we have groups of individuals who I call ravers, who they will not go to sleep. It's both initiation and maintenance, and they don't sleep for sometimes days, and then they crash. So understanding which of those categories you're in, I think, is very useful. So when you're trying to treat these, I think the first thing is consider environmental adjustments. And sometimes these are enough, but a lot of times they're not. Make sure that the atmosphere is correct, and everybody's thinking that this is the time to relax, and that starts at a reasonable time at night. And there's a period that everybody goes through to get into the mood to fall asleep. And is the bed and sleeping area a safe space? Does it have is it a safe bed for the individual? And as part of that, there are routines that you incorporate. But also think about, are there other things such that are preventing sleep, such as reflux or constipation? And then if you can't figure out what works, then I think it's time to consider medication trials. And these depend on what you're trying to treat. If it's initiation, then you think about melatonin and melatonin agonists. If it's maintenance, then it's melatonin agonists, clonidine, gabapentin, or trazodone. These are some of the medications that I use. But I think it's important to consider working with a sleep specialist, which may or may not be your neurologist. And sometimes it's important to consider a sleep study to rule out such things as sleep apnea and restless leg. In general, the way I ask the question, is sleep a problem, is I ask families, how many nights a week do you have to go in to resettle your child? And if that's more than a couple nights a week, I think that that's definitely impacting everybody's life, and you need to think about how you approach sleep disorders. GI issues. So the autonomic nervous system. So GREEs are needed here for function 2, whether it's at the brainstem or even at the level of what we call the enteric plexus, which controls how the gut works. So in general, when you think about reflux and constipation, if these are issues, treatment improves nutrition, health, and overall quality of life. Reflux, are you irpy-burpy? Are you air swallowing? Are you refusing foods, overeating, or not sleeping? So these can all be signs that reflux is an issue. And the approach that I have when I work with my GI specialists is think about adjusting the diet and then consider a trial of medications. And it's important to remember that in general, daily medications are okay. Constipation, the goal is always one soft movement daily. And if you can't get that, then you need to adjust the diet, then consider a trial of medications. Importantly, daily medications are okay, even lifelong things such as Miralax. And this is probably best. You don't want to keep going through a cycle of it's managed, you come off medications, it's not managed. You need to get there and stay there. Feeding, coughing, choking, spluttering, taking more than 30 minutes, or a flat weight curve. These are all signs that feeding is not going well. And it's not a failure to consider the need for a gastrostomy tube. And sometimes it's really important to consider a swallow study to make sure that the individual is safe to take things by mouth. As always, I think it's very important to work with a dietitian to make sure that nutrition is adequate. And I think with most people, especially if you're on anti-seizure medications, you need to consider a vitamin D supplement for bone health. Therapies, things to consider are physical therapy, occupational therapy, speech therapy, augmentative communication therapies, vision assessment with necessarily accommodations. And all of this is usually formalized into an individualized education plan. And it's important that you know your rights under the law. And here's a good website that I think is useful for families and that teaches you how to communicate with your school district or educational entity. There is a comprehensive guide in another disorder that may be of use, I think, in GRI disorders, and this is a consensus guideline on managing Rett syndrome across lifespan. So I think that you might consider having a look at that. This is a useful thing for both your primary care physician as well as the other specialists that take care of you, that presents an outline on how to approach things. So N of 1 trials. So these are where individualized outcomes and approach for each person has been determined between clinicians and the patient and family. And the outcome measures depend on preference. And really what you're trying to decide is how do you know if your intervention is working or not? And meaningful change in that measurement is going to be subjective to each person's experience. So how do you know if something improved for you is really meaningful for everybody else? In these situations, prior safety is not necessarily established, and safety measures are arbitrary, especially what do you measure and how often in order to make sure that what you're doing is safe. And if things get better or they worse, and it's not always clear how you know if this would have happened anyway without the medication. So this has happened in GRIN disorders, and these have depended on prior knowledge of the functional status of whether or not it's a gain of function or loss of function change. So in loss of function individuals, L-serine has been tried in folks with GRIN2A and GRIN2B, and there was found to be improvements in behavior, development, and EEG, as well as seizures. And there's basically been a total of 10 individuals that have been examined in the literature through this way. And it's important to note that in the study by Cray et al., where they studied 9 individuals, 1 of them actually got worse with a gain of function change. For gain of function change, things like memantine, dextromethorphan, magnesium, and ketamine have been tried. And again, the total number of individuals who have been involved with this is relatively low. And these have shown improvements in medically refractory epilepsy or even status epilepticus, that is seizures that just do not stop. So my opinions, when you look at whether or not you're a gain of function or a loss of function, there is a gray zone in this, and it's not really clear necessarily where even after doing functional testing you may stand. It could be completely obvious, but indeed there can be some gray zone. I think these are helpful to understand, knowing whether or not you're gain of function or loss of function. This is helpful to understand safety and support going forward with standardizing clinical trials. And these should have defined outcome measures and safety precautions. And I think that these should be only for extreme situations, such as an ICU admission or multiple daily seizures, and when functional status is indeed known. And if there are questions about this, your clinician can contact me for recommendations. So here's where I want to remind you again about the registry and ask the question, why haven't you enrolled yet? And if you are enrolled, why haven't you updated us yet? Because we do want to know what goes on with you as time goes past. And this is our pathway for discovering natural history. Also, if you enroll in the registry, this is how advanced functional analyses are obtained through Dr. Trainellis and Dr. Yuan at Emory are performing. There is a new portal, which is a one-stop shop. Here it's grin-portal.broadinstitute.org. And then these are the direct contacts for either Dr. Lemke's registry for folks in Europe, Asia, or Africa, or North and South America and Australia. This is the contact for either Jennifer Sargent or Dr. Bain at Simon Searchlight. Now, what we're doing between what Dr. Bain is doing versus what Dr. Lemke and we are doing is she's collecting additional measures. But in general, all of our data is meant to be uniform and standardized and sharing across those different platforms. So I hope I answered your questions today about these different topics. And if there's time during the Q&A session at the end of this, I look forward to your questions. So thanks very much.
Wow, it was great to hear from Dr. Benke, and I just wish that he were here so that we could really ask him those questions in person. But Dr. Coombs and I will do our best to answer any questions that you have. If you do have questions, I encourage you to put them in the chat of Zoom, and we will. I will see them, and I will ask them of Dr. Coombs at the end of his talk. But now let's move on, and I would invite you in to share your presentation with us. We look forward to hearing from you about perampanel.
Okay, thanks very much, Amy. Thanks very much to Kjørgen for giving me the chance to talk. What I'll be talking about is some work we've been doing with perampanel and using it as a precision treatment for Greer disorder. So as I'm sure you're all aware, pharmaceuticals are essential in the treatment of Greer disorders. We've just heard in Dr. Benke's recording a great long list of them. And these can be used for things like treating the neurological symptoms like seizures, ADHD, sleep disorders, and so on, as we've heard about, but also for things outside the nervous system as well, like the cardiac symptoms, gastrointestinal symptoms, and so on. And despite the fact that these drugs are life-saving in many cases, very few of these drugs actually act directly through glutamate receptors. And so this is kind of the approach of using two wrongs to make a right, in effect. So in the example, we have overactive glutamate receptors, we have an increase in excitation, and then we're finding other ways to try and redress that balance, to try and bring it back down, whether it might be by increasing inhibition or some other means of decreasing excitation. And there's nothing inherently wrong with this, but kind of conceptually and intellectually and kind of logically, and also in practice as well, what you'd rather be doing is only affecting one system of the brain. And the way you do that is by directly counteracting the effect on the glutamate receptors by modifying the glutamate receptors. And there are a couple of options available for this. So for example, memantine is an NMDA receptor blocker, and perampanel is an AMPA receptor inhibitor. And taken together, these might offer what we term a precision medicine. So we know the exact genetic diagnosis of why the patient has Greer disorder, and they would allow us to specifically target the source of the disease. So we're not blessed with an awful lot of options when it comes to directly treating glutamate receptors. And in terms of AMPA receptors, perampanel is the only licensed pharmaceutical which directly acts on AMPA receptors. It's an inhibitor, it's a non-competitive antagonist or a negative allosteric modulator, and now. And in terms of how it works, in terms of the receptor mechanisms, the AMPA receptor sits here in the membrane and it has its ligand binding domain open, waiting to bind glutamate. When glutamate binds to the ligand binding domain, the lower lobe closes around, and this pulls on linkers that are linked to the pore, which is then pulled open, and an electrical current can pass. Now, in the presence of perampanel, perampanel sits just towards the outside of the membrane, and it sits adjacent to the channel gate in amongst the linkers between the ligand binding domain and the transmembrane region. And when perampanel is bound, even if glutamate causes closure of the ligand binding domains, this movement is no longer transmitted to the pore, and no pore opening happens, and so no current can pass. And perampanel is licensed for the treatment of certain classes of seizures. And as with all drugs, it also has certain side effects, and particularly prominent ones include negative effects on mood. And this can include challenging behavior, even aggressive behavior of patients who are taking perampanel. So the specific study I want to talk to you about today involves a Kjørgen patient, Cole, who had a Greer 2 disorder, a defect in his Greer 2. And the first months of Cole's life were seemingly normal. There was no sign there was anything wrong. And the first clinical signs that occurred were around the age of 6 months, where he had episodes of back arching and also vomiting. At 9 months, he began showing decreased interactions and a worsening of these back arching events. And by the age of 12 months, he was having regular seizures, which led to treatment with levetiracetam, called Keppra. and also phenobarbital. So here's an example of one of his asymmetric tonic seizures that were captured by EEG. And at this time, global developmental delay became more obvious, with worsening GI symptoms, including vomiting and constipation, which led to a designation of failure to thrive because he was becoming dramatically underweight. And shortly after this, genetic diagnosis was reached, and it was found that he had a de novo variant in his GRIA2 gene, and it was a missense variant, so a spelling mistake, where an alanine in position 643 was instead reading as a valine. And this was designated likely pathogenic. And the fact that it was likely pathogenic can be seen from the sequence alignment of all of the glutamate receptors. In fact, this 9 amino acid stretch here, called cytonLAF, is found in AMPA receptors, in NMDA receptors, kainate receptors, and delta subunits, so every member of the family. And in general, when these sequences are conserved through lots of members of the family, it's because they're functionally very important. And so the location of this valine at this site in the cytonLAF motif was certainly very, very suggestive that this is what would be causing Cole's symptoms. Okay, so what we know about GRIA2 disorder is still kind of slightly up in the air. There's only been around 30 or 35 cases published. I'm sure more are on the way. But in general, it was found that GRIA2 disorder patients have neurodevelopmental delay, and also in some cases autism spectrum disorder and seizures, as in Cole's case. And in general, the reports of GRIA2 variants that have been published have shown them to be mostly loss of function, so the receptors become underactive. However, we know from the literature that variants at this exact same site across all 4 of the glutamate receptor genes have been noted to cause disease, and where they've been functionally investigated, they've been found to be gain of function. And so it was really important that we get an answer about whether this particular variant in GRIA2 was gain of function or loss of function, because given perampanel as a glutamate receptor inhibitor, this offers the potential for that precision medicine where you're directly counteracting the effect of the variant. And so if the A643B variant was gain of function, then perampanel would be very effective. However, it's worth bearing in mind that if instead the variant was loss of function, rather than being a precision medicine, this is my term, I don't expect it to catch on, but it could actually be a precision poison. So whereas in general, perampanel is not it doesn't cause dramatic changes in healthy people. If you take somebody who has a loss of function AMPA receptor variant and then give them perampanel, you go from a situation where there's already not enough activity and then you increase it even more. And so acutely, it would actually be very dangerous to give perampanel to someone with a loss of function variant. And so it was crucial that we performed electrophysiological analysis to work out exactly what this variant was doing to the receptors. And we did this by just an expression system. So we expressed the channels and we pulled upside patches, and we applied fast applications of glutamate to activate the receptors to see what they look like. And overwhelmingly, our data suggested that the A to V variant was a gain of function. So by applying short pulses of glutamate, which cause the receptors to activate and then unbind glutamate and close, a process called deactivation, we found that wild-type receptors activated and deactivated very quick, whereas the variant receptors activated quickly, but they decayed much more slowly. And this indicates that they're binding glutamate for longer, and therefore the lengthening of the signal would lead to increased magnitude ultimately of the signal, and therefore gain of function. In terms of the other means by which the receptors can close, which is desensitization, this is when you have longer applications of glutamate. Glutamate binds to the receptor for longer, but it has another mechanism by which it can close. It's kind of like a safety feature for AMPA receptors. And again, with wild-type receptors, we see they activate very quickly and desensitize fully and very quickly. With the variant, even though the kinetics of desensitization weren't accelerated, weren't changed dramatically, the extent of desensitization was greatly decreased, and they only desensitized about 50%. And so when you combine these two things together, you have a receptor that binds glutamate for too long. And we also have a receptor that doesn't desensitize, doesn't protect itself from this overactivation. You can see why the variant would be gain of function and potentially damaging. And this was also apparent from the glutamate potency of the receptor. So this is the concentration of glutamate that is able to produce openings. And so we find that a lower concentration of glutamate can produce the same level of activity. And the potency of glutamate was increased by about between 6 and 8-fold for the variant receptors. So taken all together, this shows that the variant is definitely going to be a gain of function. And so now that we have the gain of function, we have the potential for perampanel to be this precision therapy. It was important to see, of course, that perampanel did actually inhibit the receptors. And we found that indeed they did inhibit the receptors. However, it wasn't quite straightforward because the potency of perampanel to inhibit the variant was actually around approaching 10-fold less than its potency to inhibit wild-type receptors. And so you need a much higher concentration of perampanel to inhibit the variant receptors. But nonetheless, you do get there in the end, and you can fully block the receptors. The mechanism for why this is the case is likely to be the location of the variant, which is towards the edge of the transmembrane region, and it's actually very close to the position of perampanel binding. So perampanel, the green molecule here, the alanine residue in purple here, is just adjacent to the perampanel binding site. And so the incorporation of a larger side chain is likely to cause some structural changes around here, which are likely to slightly change the binding pocket for perampanel, hence decreasing its potency. But nonetheless, we've demonstrated that the A to V variant is gain of function and that perampanel can inhibit the currents. And so the decision was taken at this point that it should be safe to start treatment for COL. It's especially important that all this data was in place because actually perampanel is only licensed for children as young as 4, and COL was still just 2 at this point. So without a really strong basis for the off-label usage of the drug, it would be very, very hard really to start him on this therapy. Okay, and so the most easily quantifiable aspect of an anti-seizure medication is to see does it decrease the level of seizures, and categorically it does. In the seizure load in the aftermath of perampanel was on average less than 3 a month. Whereas if you look at it beforehand, you see clusters of up to 12 in a single day, up to 30 in a week. And of course, this was in the presence of 2 very commonly used anti-seizure medications, phenobarbital and levetiracetam. And so these are 2 examples of that 2 wrongs make a right kind of approach, but by trying to increase brain inhibition with phenobarbital and to decrease the mechanism of levetiracetam is a bit less clear, but it likely decreases presynaptic release of glutamate. So you have less excitation and more inhibition. But despite that, there were still lots and lots of seizures that were being experienced. The overall, the maximum dose of perampanel was very well tolerated. And when perampanel was doing its thing, it was possible to completely remove Keppra levetiracetam from the treatment regimen. And there's still ongoing at the moment. There's still a decrease in phenobarbital dose, but you can see that at the moment seizure control seems to be very good. Now, the reason I've got this up here, this little asterisk, is because we can't ignore the fact that many different things were being tried for COL, and it certainly seems that the modified Atkins diet, which kicked in here about 2 or 3 months before perampanel use, which is similar to the ketogenic diet that some of you may be familiar with, and this also probably contributed to the success because it did seem there was an initial slight decrease in seizures before perampanel was started, probably as an effect of the modified Atkins diet. Okay, so this was the effect that we predicted. Really, we had a known anti-seizure medication that was directly targeted to counteract the effect of the variant. But of course, Cole's symptoms, as I described, were more complex than that. They were more complex than just seizures. He had the failure to thrive issues from the gastrointestinal symptoms. He had various developmental delays, both in physical and social delays. And so we were very interested to track progress in that regard as well after his perampanel treatment. And many thanks to his mother for supplying some pictures. I will warn you, it's about to get cute. Okay, so what we find is that he has definitely seen benefits beyond just seizure control from his current treatment regimen. So the GI symptoms that were such a really strong feature of his early clinical signs no longer seem to be of concern. He had a couple of GI meds, erythromycin and Prilosec, that he's now been weaned from. You can see he's now a big, strong boy, and his failure to thrive has resolved. So he was below the 1000th centile in terms of weight before perampanel started, and now he's up to much more healthy between the 15th and the 25th centile. And he's also, physical development has also accelerated. So whereas before he was showing delays in things like grasping and reaching, use of his hands, he's now doing these things. He's now sitting independently and for long periods, and can also wait there in quadruped. And he's moving on to gait training to help advance some more of his movement. And then finally, some of the social delays have also started to be caught up on. So his interactions increased, his facial recognition, his eye contact. I've got to get me some blue ones. And he can understand and can follow certain instructions, and can verbally respond yes and no to questions as well. So he even has a few words. So all of these skills that he's developed really seemed out of reach before he started the perampanel. And finally, and scientifically, a very, very interesting point is that the side effects that are commonly seen, particularly at these high doses of perampanel, so he's right at the maximum dose, despite being below the minimum age, if you see what I mean. He doesn't seem to be having these side effects at all. And in actual fact, it's quite the opposite. He actually seems to be exceedingly cheerful after his perampanel dose, with lots of kind of laughing and smiling and so on. And so, yeah, just in conclusion, so we identified this variant as being gain of function, and we demonstrated in experimental systems that perampanel might be of use, and also perampanel treatment has proven to reduce these seizures and seems to have coincided with clear developmental gains. And so obviously more research needs to be done. We can't say anything with certainty. We don't, obviously a year is a very, very long time in any child's development, whether they have Greer disorder or Gree disorder or not. But nonetheless, it does seem that perampanel should be considered for patients with other known gain of function variants. And also it's worth bearing in mind that potentially to be considered even in the absence of seizures, even when seizures are either absent or are controlled through other means. That doesn't mean that perampanel shouldn't be considered, because at this early stage, we can't be certain that, or we can't know one way or another whether perampanel was very much responsible for all these other gains as well. Okay, so thanks very much to the Medical Research Council, who fund the lab of Mark Farrant and Stuart Kilcandy, and also thanks to Volo, a postdoc in the lab, who will help me with some of these experiments. And of course, the doctors at the University of Michigan, so Dr. Ziobro, who's leading Cole's care at the hospital, and also Dr. Surtees, who was responsible for actually reaching out, and we took Yogrin, and that's how we got involved in the first place. And of course, Cole and his family for their data gathering. We can't know those seizure numbers without their help, and also his whole healthcare team, without which I'm sure we couldn't have possibly hoped to see such a great result. So thank you very much.
Thank you very much for that heartwarming and exciting story. I just want to say congratulations to all of you, and that was some wonderful research that you did. We have 5 minutes before this automatically goes away, so I want to very quickly make sure that we cover this question that was asked. Let's see. The question is, does this have any application to other GRE disorders with a gain of function, or is perampanel limited in effectiveness only to GRIA? My son has a GRIN2A. Can you comment on that?
Physiologically, AMPA receptors and NMDA receptors are very much linked. You know, they influence each other's behavior. I would say, though, that in terms of this being called a precision therapy, I would say that using perampanel for other gain of function variants has less of a solid basis. But I mean, that doesn't mean for sure that it wouldn't be worth considering. So, for example, kind of turning it slightly around, we heard a GRIA2 mum talk earlier in the day, and she mentioned that they were going to try starting L-serine therapy, which is so this is something to upregulate NMDA receptors. And so, even though her daughter's condition was linked to lower AMPA receptor function, the potential benefits of upregulating NMDA receptors, you know, there's a potential there, because even though having underactive AMPA receptors is plenty bad enough on its own, that has a knock-on effect in terms of that will also lead to underactive NMDA receptors, because you need to have enough AMPA receptor activity before your NMDA receptors can be activated. And so by trying to upregulate the NMDA component, you stand a chance of at least part rectifying the AMPA receptor defect. And I guess you could potentially apply similar logic, but I think that's the kind of question actually that Dr. Benke would certainly be the best person to ask. Yeah.
I'm sure he'll be here for the next for our next in-person meeting. Hopefully he will. But thank you for that, very careful answer. There is a question about GRIA loss of function patients. Are you aware of whether they also experience seizures? I believe that they do, but you're closer to the GRIA community than I am.
It's still unclear. There are certainly reports that loss of function GRIA2 variants have been reported as seizures, as having seizures. Whether I mean, there are still kind of high quality, sorry, that's me very much blowing my own trumpet, but when by the approach we use of pulling patches off cells and then doing fast glutamate applications, that's kind of really key to understanding the relevant synaptic properties of AMPA receptors, because you can, it's relatively easy to record from a whole cell, a whole transfected cell, but you just can't activate the receptors quickly enough. You can't activate them like they would be actually at a synapse. And so until that work is done on all of the GRIA variants, it's going to be difficult to be sure. Now, I know that the team, Steve's analysis team at Emory, believe they're going to publish something this year. I'm not quite sure exactly when it's going to come out, and there'll be a lot more information there. And that'll really help to swell our database, so to speak, of understanding. What's going on. But in general, if you find that your AMPA receptor is loss of function, it's very unlikely that perampanel would be helpful, and potentially quite damaging. So.
Excellent. I think that there's a parent who might be answering this other question, but I'll read it out anyways. An earlier presented study showed high prevalence of seizures in GRIN2A at 10 years old for null variants. Is this the same for GRIN2B patients? And I would say yes, that there are indeed seizures observed in GRIN2B loss of function variants as well. Do you have any comments on that, Dr. Coombs?
I'm nowhere near as familiar with the GRIN literature, I'm afraid. I think I'm just trying to remember. I think possibly even Dr. Benke had a slide about it in his recording.
Yes, I believe.
I can remember it to that detail.
Yes, yes.
I can't remember the contents.
So yes, I think unfortunately with seizures, that doesn't seem to be the thing that can differentiate gain or loss of function. And I think, you know, the excellent electrophysiology that you did. I was wondering, how can you apply the glutamate in such with such precision for the, you know, to look at just the simple spike versus desensitization kind of regimen. I think that's quite impressive.
Yeah, well, I mean, the techniques are established, and many labs can do these techniques. But the actual mechanics of it, I can't greatly vouch for. But ultimately, what happens is you apply a very short electrical voltage across what's called a piezo crystal, and that causes a movement. And you can make that movement happen for less than a millisecond if you want. And so by attaching a piece of glass that has got a division down it with control solution on one side, glutamate solution on the other side, you can position a little patch of membrane in front of it, and then and it allows you to. It's not truly synaptic. The rise time can approach the rates that you see synaptically, but the decay, it's like kind of a rectangular application, whereas in the synapse it diffuses away and the concentration decays slightly differently. But to all intents and purposes, it gives us a really clear view on key synaptic properties. So
I guess then the take-home message is that because there's also this desensitization component that you need to look at, that it's maybe more difficult for AMPA receptors than it is for NMDA receptors to make this distinction of gain or loss of function. Am I understanding that correctly?
Yeah, I mean, there's certainly the prospect for things to be complex. So, for example, you could have very, very commonly the variants that you see in glutamate receptor genes. Sorry, that is my cat clawing the door. Ignore it. It's not one of the kids locked up. Sorry, I've distracted myself now. What was
I saying? About distinguishing between gain and loss of function. But
yes,
I am afraid
right.
we're almost out of time.
So anyway, a particular change that causes up or down regulation can lead to reduced folding and reduced trafficking. So you can have reduced numbers of a more active receptor.
Right on top of that. So I think that's the answer. So okay, it is unfortunately time for us to wrap up. I'm getting the message that we need to. But I have just learned that Dr. Benke will be present for the Ask Me Anything session. So he might be able to answer some of those questions that we were not sure about, including this one about, there was a question about whether seizures are more frequent to come with an onset of puberty. So I think that he'll have a great answer for that. Thank you so much for your presentation, your science. Congratulations. So happy for Cole.
Yes, yeah, no, it's a great result,
A wonderful story. Thank you so much. Thank you to all of you for joining.